session of Bodhana. This is the 20th session. So organized by TNFOG, by our president, Dr. Revathi Janakirao ma'am, Dr. Sampath Kumari ma'am, Secretary TNFOG, and Dr. Kalpana ma'am. So we'll start this interesting session. The welcome address by Revathi ma'am. Dr. Revathi Janakirao ma'am.
Hey, time waste President TNFOG, that's all. Okay, fine.
Yes, ma'am.
Okay. Good evening, all. It's indeed a great pleasure for me to welcome you all to this PG training program of TNFOG, which is the brainchild of Dr. Sampath Kumari. And not only postgraduate students, but also all of our members showed keen interest in attending this to gain knowledge. I'm very happy about it. And I welcome the presenters, Dr. Saranya and Yuvarani, and also examiners, Dr. Anita from Dharmaburi, and Dr. Padma Priya also from Dharmaburi, and external examiners, Dr. Sumati and Dr. Shanmugavadigal. And I am sure all the postgraduates who are attending this will be definitely benefited. And I welcome all those delegates, postgraduate students, as well as all our members to this Bodhana session. Welcome you all.
Okay. Thank you very much, ma'am. Thank you for your blessings. And we will start this session. May I request Dr. Anita ma'am, Anita Tamari Selvi ma'am, who is a professor of OG, Government Dharmaburi Medical College Hospital.
Good evening, ma'am.
Good evening. And Dr. R. Padma Priya, Associate Professor of OG, Government Dharmaburi Medical College Hospital.
Good evening, ma'am. Good evening.
And Dr. C. Sumati madam, Professor, Department of OBG, Institute of Social Obstetrics and Government KGH. She has 30 years of government service, 25 years of experience in the field of obs and gynae, UG and PG teacher, and she's been our teacher as well, and master trainer in emergency obstetrics, specially trained in colposcopy. Areas of interest are cancer screening and social obstetrics. Welcome, ma'am. And I invite Professor Dr. L. Shanmugavadigal, Secretary, Obs and Gynae, Society of Salem, Professor Medical College Hospital, Salem, with 16 years of appreciable service to our medical field, untiring teaching experience for both UGs and PGs, and she's published articles in national and international journals, has special interest in the field of high-risk obs and gynae and endoscopy. Yeah, welcome.
Thank you, Radhika.
Thank you. Dr. Sharanya, final year PG, Government Dharmaburi Medical College Hospital. Welcome you. And Dr. Yuvarani, final year PG, Government Dharmaburi Medical College Hospital. Welcome, Dr. Yuvarani. So we'll start this session with the doctors now. Discussion on ovarian cancer.
You can start presenting.
Present, okay. Can you please start? No?
Yes, ma'am.
Slide.
Ma'am, please make it full screen.
Click the slideshow bar.
Yuvarani, full screen put you start presenting, ma.
And the slideshow click பண்ணுங்க.
Slideshow போடுக்கண்ணா.
என்ன ப்ராப்ளம் பா?
Unable to share the slide, ma'am. Sorry, ma'am.
Slideshow போடுமா தெரியுதுமா? பெருசா தெரியும். சின்னதா தெரியுது, பெருசா தெரியுமா? Once stop share and reshare it, ma'am. Close all the tabs. Stop share and reshare it, ma'am. Yes, now please click on slideshow. Okay, ma'am. Okay. Start, ma'am.
Old Mrs. X, Para 1 Live 1, a postmenopausal woman, last childbirth 39 years, not sterilized, housewife by occupation, belonging to lower middle socioeconomic class according to modified Kupasamy scale came with chief complaints of abdominal distension for past 6 months and lower abdomen pain for past 1 month. History of presenting illness. The patient was apparently normal before 6 months, after which she developed abdominal distension, which is insidious in onset, progressive in nature. Patient also had complaints of abdomen pain for past 1 month, which is insidious in onset, progressive in nature, dull leaking in character, radiating towards flanks, aggravated on physical activities, and relieved on taking medication. Patient also had history of heaviness in lower abdomen, history of difficulty in breathing on exertion, history of increased frequency of micturition, history of early satiety, history of loss of appetite, history of loss of weight, history of bloatedness of abdomen for the past 1 month, no history of postmenopausal bleeding, no history of irregular bleeding per vaginum, no history of vaginal discharge, no history of constipation, no history of vomiting, no history of mass descending per vaginum, no history of pedal edema, and no history of varicosities of the lower limb. Menstrual history. Patient attained menopause 15 years back. Previously, her cycles were regular, 4 by 30 days. Menarche was at 14 years of age. Marital history. Married at 20 years of age. She conceived after 1 year of marriage. No history of occipitals usage. Obstetric history.
So for the history of occipit usage, what is the advantage of taking occipits?
Ma'am, usage of occipits for 5 years, it reduces the risk of ovarian cancer by 50%, ma'am, and it moreover provides protection for nearly 15 years, ma'am.
Okay.
Obstetric history, para 1 live 1. First childbirth was at 21 years. It was full-term normal vaginal delivery, not sterilized. No history of infertility treatment. No history of ovulation induction. History of breastfeeding for more than 1 year. Past history, no history of similar symptoms in the past, no history of diabetes, hypertension, epilepsy, TB, cardiac disease, asthma, no history of blood transfusion, no history of previous surgery or drug intake. Family history, no history of breast, ovarian, colon, endometrial cancer in family. Personal history, consumes mixed diet, no history of smoking, tobacco, and alcohol intake. General examination.
Family history, how will you analyze regarding the genetic mode of transmission?
If the patient has early onset of ovarian cancer or patient has a personal history of breast cancer, or else if any one of her first degree relative with history of breast to ovarian cancer or with history of endometrial or colon cancer, we can do genetic analysis, ma'am. We can screen the patients, ma'am. BRCA1 and BRCA2 mutation has increased risk of ovarian malignancies. BRCA1
pedigree analysis, okay, just
pedigree analysis.
Both maternal and the paternal side, you should put the pedigree analysis, okay. And also the age of onset of the ovarian cancer in their relatives. Based on that, these patients you can analyze when at the age of onset for this patient. Okay.
Okay.
Okay, continue.
General examination. Patient thin built and poorly nourished, pallor present, no icterus, no cyanosis, no clubbing, no pedal edema, no significant generalized or supraclavicular inguinal lymph node enlargement. Vitals, temperature afebrile, pulse rate 82 beats per minute, BP 140/80 millimeter mercury in right upper arm in sitting position, respiratory rate 18 breaths per minute. Height 157 centimeter, weight 45 kg, BMI 18.7 kg per meter square. Breast examination, no palpable mass, no discharge. Spine examination normal, thyroid not enlarged. Systemic examination, cardiovascular system, S1, S2 heard, no murmur. Respiratory system, normal vesicular breath sounds, no added sounds. Central nervous system, no focal neurological deficit. Abdominal examination, inspection. Abdomen distended, umbilicus shifted upwards in midline, flushed with surface. Skin over the swelling normal. No dilated veins, no scars, no sinuses. All quadrants moves equally with respiration. Hernial orifices free, flanks free. Palpation, not warm, not tender. Mass of size 20 cross 15 centimeter arising from the pelvis, occupying right and left iliac fossa, right and left lumbar region, hypogastrium, umbilical region, and extending up to epigastric region, which is variable in consistency, irregular surface, borders felt all around except lower border with restricted mobility, no palpable organomegaly due to mass. Percussion, dullness over the mass, no shifting dullness, auscultation, normal bowel sounds heard. Examination.
Clinically differentiate between benign and malignant ovarian mass. It's as such a UG question only, but you can answer.
Right from the age, ma'am, benign mass will be presenting premenopausal. Malignant mass can occur either perimenarche or in the postmenopausal age group. And the growth of the mass, the benign mass will be slow growing, whereas malignant will be rapid growing. Laterality, benign mass will be unilateral and malignant mass will be bilateral. And it includes the examination of the mass, which is benign mass will be solid or cystic. Malignant mass most often will be solid. Consistency, which is consistency, followed by the surface. Benign mass will be smooth, whereas the malignant mass will be irregular in surface. Borders, it is borders will be felt, and mobility, regarding mobility, benign mass will be freely mobile and malignant mass will be fixed with restricted mobility. And then ascites and metastasis will be present in the malignant mass, whereas which will not be seen in the benign mass.
Okay. Okay, continue.
Examination of external genitalia, pubic hair sparse, labia majora and minora atrophied. Perspiculum examination, cervix flushed with walled, pinhole os, no abnormal discharge, no UV descent, uterovaginal descent. Bimanual pelvic examination, cervix felt in mid position, flushed with the walled, exact size of uterus could not be put out. Mass fell through all the cornices, cornicial fullness in the anterior, right, left cornices. Posteriorly, nodularity felt, no transmitted mobility, and group sinus not felt. Parectal examination, rectal mucosa smooth, freely mobile, parametrium normal, nodularity felt anterior to rectal mucosa. Summary. 60-year-old postmenopausal Paris woman, not sterilized, with complaints of abdomen distension for past 6 months and abdominal pain for past 1 month, along with other positive GI symptoms and urinary symptoms, presented as a mass of size 20 cross 15 centimeter, which is arising from the pelvis, occupying up to epigastric region with variable consistency, irregular surface, and restricted mobility, is probably an abdominal pelvic mass which needs to be evaluated further.
Anita, நீங்க எதுவும் கேட்கணுமா Anita history examination?
இல்ல நீங்க கேளுங்க, பசங்க ஆன்சர் பண்ணலனா.
சரி, இல்ல நீங்க ஏதோ ஆட் பண்றதா கேளுங்க. History wise. ரேவதி மேடம்.
மேடம் அப்புறம் ஜாயின் பண்றேன் நாங்கப்பா நடுவுல.
ஓகே.
நீங்க இது பண்ணுங்க, கேரி ஆன்.
How will you proceed with this case, ma'am?
Yes, ma'am. My patient
Karanya, you can answer.
My patient is a 60 years old postmenopausal woman. I have to confirm the findings, clinical findings. I have to do ultrasonography, both abdominal, transabdominal ultrasonography and transvaginal ultrasonography. So transabdominal ultrasonography specific for the ovarian mass and transvaginal ultrasonography specific to see the uterus.
Can I interrupt for a minute?
என்னது?
இல்ல ஒரு நிமிஷம். Can we, from the basic investigation, you should start from the usual, no? Basic investigation.
Basic investigations. Why you say?
You always
Karanya.
start with the basics, no?
Okay, ma'am.
The usual ones, so that they'll be fit. You're going to post correct the HB and all that, no?
Ma'am, I have to do basic investigations like hemoglobin, platelets, renal function test, liver function test, and serology, and chest X-ray to rule out any pleural effusion or pulmonary metastasis, and blood grouping and typing, ma'am.
And examine breast also.
Okay, ma'am.
Secondaries irukkalamla.
Yes, ma'am.
Okay, continue.
Okay, you carry on.
Okay, ma'am. Then I proceed with the ultrasonography to differentiate between benign and the ovarian. To benign and the malignant ovarian mass by IOTA classification. IOTA rules, that is International Ovarian Tumor Analysis, B rules and M rules. In B rules, the unilocular tumor and the presence of solid component, which is less than 7, largest which is less than 7 mm of diameter, and acoustic shadowing, and a smooth irregular cystic mass of diameter less than 10 centimeter, and the color score 1, that is no blood flow. And malignant M rules, this is an irregular solid tumor, presence of papillary excrescences at least 4, and presence of ascites, irregular multilocular solid tumor of size more than 10 centimeter, and strong color flow of 4. We can
Okay, but in the postmenopausal women, in postmenopausal women, is the size matter or
volume of the tumor matters, ma'am.
Postmenopausal women, any mass, any ovarian mass with solid areas, you have to, any cyst with along with solid areas, you have to consider it as malignancy only. Okay. This one, what you say, it's for all the size of the mass is for the perimenopausal women. Okay. Okay, continue. How you complement other, what other investigations you will do?
Ma'am, tumor markers, ma'am. So I have to do CA125.
So ultrasound alone is enough in imaging for you.
No, we can do CT abdomen, ma'am. Before planning any surgery, we can do CT abdomen for abdominal
metastasis. Before planning, sir, before this, for anything to know the nodal metastasis, you should know. You should do a CT abdomen. Contrast CT is better than a plain
CT, ma'am.
Okay, you should do a contrast CT abdomen and pelvis. Okay, then.
CT we can't. Yes, ma'am. In CT, we cannot differentiate between benign and malignant. And moreover, if the metastasis is less than 2 centimeters, we can go for MRI, ma'am. It is more sensitive compared to CT, ma'am. And then chest X-ray is done to rule out the metastasis, pleural effusion, ma'am. And we can do upper GI endoscopy, barium enema, colonoscopy, intravenous pyelography to rule out the primary sites, ma'am. Because
you do, if there is any ultrasound, if you do any, if you have hydroureteral nephrosis, you do IVP. Or else it's not needed. Usually the ovarian mass, the ureteric involvement will be very less only. Okay, it's rare. But in you have to do in case of bilateral ovarian mass, always you should rule out secondaries. Okay, primary from the other side. Primary from GI, upper GI and lower GI, and also from the breast. Breast you should palpate for any mass. Any breast mass is there, or you can primary, always in bilateral ovarian mass, you should rule out the secondary ovarian malignancy. Okay, then continue. The role of any PET CT?
Yes, ma'am.
Before for diagnosis, you need?
Diagnosis, it is of no rule, ma'am, nowadays. So
just for diagnosis and for staging, PET CT is not needed. CCT or MRI is enough. Along with that, you do a upper GI and lower GI endoscopy. Okay, okay. Continue.
What are the serum markers we have, ma'am? CA125 for epithelial ovarian cancer, but it is very less sensitive in early stages. Only up to 50% is the sensitivity, whereas in advanced stages, it is nearly 70 to 80% sensitive, ma'am. For mucinous pathology, we have CEA and CA19-9, ma'am. And human epididymal protein 4, it is expressed by the epithelial ovarian surface. It is also used for screening epithelial ovarian cancer in early stages, ma'am. It is more sensitive compared to CA125 in early stages, ma'am.
Okay. Then now, other investigation, please, elderly women, any other investigation?
ECG echo, ma'am. We have to make sure whether she, her performance status, whether she's fit for surgery. We have to look for ECG and echo, ma'am.
Okay. Then how will you proceed with the case? What you're planning for a
surgery? We have to stage the patient, ma'am, which is done in surgical. According to people. We have 4 stages, ma'am. Stage 1, stage 1A, the tumor is confined to one ovary. Stage 1B, it is confined to both ovaries. Stage 3 has got C1, C2, and C3. C1, it is surgical spill. C2 is preoperative rupture of capsule. And C3 is ascites or peritoneal washings, which is positive for cytology. Then moving on to stage 2, we have 2A and 2B, ma'am. 2A is involvement of uterus and tubes. 2B is other intrapelvic structures, which is bladder, rectum, and sigmoid colon. Then we have 3, ma'am. 3 is retroperitoneal retroperitoneal lymph node involvement or other intra-abdominal metastasis. 3A is positive retroperitoneal lymph node involvement, and 3A1 has got two subdivisions from 3A1 and 3A12. In that, we are taking into consideration the greatest diameter of the lymph node metastasis, which is less than 10 millimeter in 3A1 small 1 subdivision, and 3A1 small 2 subdivision is more than 10 millimeter. Then we have stage 3B, ma'am, where there is microscopic peritoneal metastasis, and 3C, 3B, there is macroscopic. 3B, there is
Continue.
microscopic abdominal metastasis less than 2 centimeter, and 3C, it is macroscopic abdominal metastasis more than 2 centimeter. More than 2 centimeter, ma'am. And we have 4A and 4B. In 4A, 4A, which is distant metastasis, involvement of lungs, pleural effusion, and 4B, it is a positive inguinal lymph node, or 4B, there will be involvement of parenchyma of liver and spleen, ma'am. And 3C, there will also be involvement of capsule of spleen and liver, ma'am.
Okay. Then what you want to do?
Surgical.
How will you do a staging laparotomy?
Laparotomy, ma'am. So,
Saranya, you can answer.
Okay, ma'am. Open the abdomen by midline vertical incision extending from the zippy sternum to the pubic symphysis. So we have to take the ascitic fluid for a cytological examination. If there is no ascitic fluid, we have to do peritoneal washings with 50 to 100 ml of normal saline, and take samples from the paracolic gutters and undersurface of the diaphragm and POD, and then inspect the mass, ovarian mass and uterus, and then systemic inspection and palpation of the abdominal organs in a clockwise direction, starting from the cecum, right paracolic gutter, ascending colon, hepatic flexure, undersurface of the diaphragm, right hemidiaphragm, and undersurface of the liver, gallbladder, transverse colon to splenic flexure, and undersurface of the left hemidiaphragm, spleen, and then descending colon to left paracolic gutter, sigmoid colon, rectum, and then pouch of Douglas, and omentum and mesentery, and retroperitoneal area. Then proceed with total abdominal hysterectomy with bilateral salpingo-oophorectomy. Then proceeded with pelvic and para-aortic lymph node dissection. And we have to do peritoneal biopsies. If any suspicious areas or adhesions on the peritoneum, we have to do biopsies. If there is no suspicious areas, we have to do biopsies from 2 paracolic gutters and from undersurface of the diaphragm and from intestinal mesentery, bladder peritoneum, and from the pouch of Douglas. Then we have irrigate the abdomen peritoneal cavity, then kept the drain, and after attaining hemostasis, close the abdomen, ma'am.
Momentum?
Momental intracolic mammectomy, pelvic and
Mammectomy.
lymph node dissection. If the momental metastasis is more than 2 centimeter, we have to do total omentectomy, ma'am.
So you should do a supracolic omentectomy. So first you start from the stomach and do, or else if there is no involvement, you can do a infracolic
From the transverse colon.
Below the transverse colon, hepatic and splenic.
So what if it is stage 3 or stage 4 disease, what you will do? You will just close and come, or what you will do?
Ma'am, if it is operable, I will do optimal cytoreduction, ma'am. If the patient,
Okay, so any stage of disease, you should try to do a primary optimal cytoreductive surgery. You just when you will not do cytoreductive surgery?
Inoperable cases, ma'am, that there is involvement of photohepatis, undersurface of the diaphragm, undersurface of the liver, and
Small bowel mesentery and lesser omentum.
And also, if there is any bowel involvement, if there is small bowel, larger areas of small bowel involvement, you will not do a primary cytoreductive surgery. Instead of that, what you will do?
Neoadjuvant chemotherapy, ma'am. I will do
But before that, you should need a histopathological diagnosis. So always, whenever you are opening, you do a
ascitic fluid cytology. I will take for
many of the time when you are doing just ascitic fluid cytology alone, you will not get positive for malignant cells. So you try to get some biopsy. You have already opened the abdomen. You in later stages, you do a biopsy. You take a biopsy for histopathological examination. So always the oncologist will not give chemotherapy without any histopathological diagnosis. So just ascitic fluid alone is not enough. So you have to do a histopathological, you need a biopsy. Okay. So always try to do a primary cytoreductive surgery. So what you said is optimal cytoreduction?
The residual tumor is less than 1 centimeter, ma'am. We have to remove as much as tumor as possible to make the tumor less than 1 centimeter is optimal cytoreduction.
Less than 1 centimeter.
Okay. So how will you grade? It is a low grade, low risk and high risk disease, ovarian malignancy.
Low risk disease, stage 1A, grade 1 and 2, and stage 1B, grade 1 and 2 are low risk disease, ma'am. Then stage 1C and stage 2 are high risk disease, ma'am.
So based on what you say, based on the
Based on stage, ma'am, grade, lymph node.
stage or
ascites,
that involvement of
capsule
whenever there is peritoneal breach or
yes, ma'am,
grade of
capsule
the
or a
tumor,
tumor,
grade of the
grade of
tumor, grade
Grade of
1. Grade 1 is mild, low risk disease, but when it is grade 2 or grade 3 disease, it is high risk disease. Then when after surgery, then you don't have the optimal cytoreduction, then also it is a high risk one. Okay. So then what you plan after that? For whom all you give chemotherapy, for whom you need not give chemotherapy?
stage 1A, 1B, grade 1 and 2, ma'am.
Okay.
We don't want
To give
chemotherapy, ma'am. Stage 1A, 1B, grade 3, and stage 1C, stage 2, stage 3, and 4 will be giving adjuvant chemotherapy, ma'am. 3 to 6 cycles will give once in 3 weeks, ma'am.
Okay. So what chemotherapy you prefer?
Some paclitaxel and platinum compounds, ma'am. Paclitaxel, injection paclitaxel, intravenous, 175 milligram per meter squared on IV, and carboplatin, area under curve 5 to 6 on IV.
Every 3 weeks once for 6 cycles will do, ma'am.
Okay. So you prefer carboplatin, then
Yes,
cisplatin. Now we are preferring
Ma'am, first and
carboplatin because the toxicity is
less
less
compared to cisplatin, ma'am.
Okay. So the low risk tumor is always that low grade tumor, and there is no capsularly, that intact capsule, no ascites, and no, that is what you say.
Capillary excrescences.
No negative, no peritoneal cytology. It's not positive. And during surgery also, the tumor should be intact. You are not rupturing the tumor, and it is a diploid tumor, and there is no addition, no dense addition. All this considered as low risk one. Okay. And the other thing, whenever there is high grade tumor and there is involvement of the surface and preoperative rupture, dense addition, aneuploid tumor, all these are high risk disease. Okay.
High risk tumors.
High risk tumors. Okay. So
How did you decide about the drug, ma? Why did you decide for this drug? Chemotherapeutic drug. Why did you decide for cisplatin and carboplatin and paclitaxel? You didn't mention this is an epithelial tumor.
Yes, epithelial tumor, more sensitive for taxanes and platinum compounds, ma'am. Mechanism.
So you have to confirm that and then you have to start. You should tell that. That is why madam was telling the pathological diagnosis is very important.
Okay.
What is the type of cells?
So any other, apart from this chemotherapeutic agents, any other drug you want to add?
Yes, ma'am. Targeted therapy, ma'am. It is bevacizumab, which is a monoclonal antibody, which is acting against vascular endothelial growth factor, ma'am. It can be given along with the regular combination chemotherapy, 15 milligram per kg every 3 weeks, once for 6 cycles, or it can also be used as a maintenance therapy, ma'am.
Okay.
15 months.
But what's the, it's quite costly here, but it is not in our setup, it's not routinely given in the government setup, but in a private setup they give. Okay.
Yes,
In our because I think your institute don't have the oncology department, but here we have, but routinely they don't give bevacizumab. They give only platin and paclitaxel. Okay. But if facilities are available, it's better to add the monoclonal antibodies. Okay. And
So few practical things. What if CA125, in which other conditions CA125 is raised?
Yes, ma'am. We have gynecological conditions such as pregnancy, fibroid, menstruation, adenomyosis, endometriosis, pelvic inflammatory disease.
Pregnancy, is it raised?
Ma'am, yes, ma'am.
No, I don't think so. Inflammatory conditions, it will be raised.
Okay.
Tuberculosis also sometimes, but
TB,
Okay.
TB,
and ref,
yes, ma'am. Non-gynecological conditions such as cardiac failure, liver failure, renal failure,
okay.
diverticulitis.
No, we limit to gynecology. Okay. So, there is a cutoff up to which gynecologists can perform the procedures, beyond which we have to refer to the oncologist. If it is a ovarian cyst with a particular cutoff of CA125.
I mean, postmenopausal woman, the cutoff is more than 35 international units per liter, ma'am.
Okay, premenopausal
woman, it is more than 200 international units.
Very good. Okay. Good. Saranyano. Okay. Is there any more case?
Ma'am?
What is the role of PRP inhibitors?
It's for maintenance therapy, ma'am. Poly-ADP ribose polymerase inhibitors, ma'am. It is used for maintenance therapy, ma'am. So,
where you do the maintenance therapy?
Ma'am, after cytoreductive surgery for maintenance therapy and for recurrence,
ma'am. Especially in BRCA1 and 2 positive carriers, it is more effective, ma'am, PARP inhibitor, sir.
Okay, so you when there is no optimal cytoreduction following chemotherapy, you give the maintenance therapy with PARP inhibitors. Okay, and how will you follow up the case after surgery and chemotherapy?
After chemotherapy, ma'am, for the first 2 years, every 3 months once I'll follow up, ma'am. And then for the next 3 years, I'll follow up every 6 months once, and thereafter annually. During every time, I will ask about the history. I'll do physical examination, pelvic examination, ultrasound, and the CA125 levels.
Okay, you need enough, or you need a CT is needed for follow up.
CT
is needed or not needed?
Ultrasound is enough to follow up.
So when there is no when you have done already a optimal cytoreduction and there is no residual disease, just follow up is enough with the ultrasound examination.
Okay.
But when you have left that there is no optimal cytoreduction, it's better to follow up with the CT and CA125. Okay.
So what are the complications do you expect during the procedure, laparotomy, when you do the staging laparotomy? You have to get a consent from the patient. So what are the things you will tell her?
Ma'am, before planning the surgery, if the patient is in a reproductive age group, I will tell first I'll do unilateral salpingo-oophorectomy, I'll do frozen biopsy, and then I will proceed with hysterectomy and bilateral salpingo-oophorectomy if needed, ma'am. And moreover, if there is extensive disease, there will be upstaging of the disease. I'll explain regarding the optimal cytoreduction to the patient, ma'am. Sometimes there will be upstaging of the disease, and then I'll remove the tumor as much as possible in cytoreduction. And sometimes
so for this case, what are the complications do you expect in this 60 years?
What other organs may be involved? Injury to other organs should be explained. Finally, at the end of the surgery, you put you do a colostomy and you do suprapubic catheterization and with multiple tubes you are sending the patient out. Surely they will ask you the questions. So what are the preoperatively, what are the consent you will ask regarding the surgery?
Bowel injury.
What are the complications you will expect?
Bowel injury and bladder injury, maybe ureteric injury also, ma'am. Blood transfusion and ventilatory support, ma'am.
Blood transfusion, ventilatory support, I guess.
So whenever you are doing a surgery for the stage 3 and stage 4 disease, always you follow the precautions which you do for any bowel surgery. Okay. So bowel preparation should be done, because at the time when you are opening, normally for routine gynecological procedure, you don't do a bowel preparation. You just give a one-time enema, or you give a morning enema, or just you give you do the surgery. But here, when you are planning for when you are planning for surgery for stage 3 or stage 4 disease, or whenever you are operating for endometriosis, severe endometriosis, always you should do a bowel preparation like you are doing for a surgical. When you are planning for surgery like bowel, any other bowel surgery, you have to do a bowel preparation. Okay. And also
Peg
get the
leg edema.
consent for injury to the bowel. And if possible, you can do a bowel anastomosis, or many of the time they do a colostomy. So for that also you have to get the consent. Okay.
And if you expect to anticipate ureteral, large one compressing the ureter or expect ureteric injury, sometimes can happen during the surgery. So you can even stent prior to the procedure. Okay. Then
So before that surgery, you personally see the MRI and the or the CT film, so that you can see whether there is any involvement of the
Bladder,
whether it is compressing the bladder, bowel, or so not bowel you cannot see, or the ureter you can see. And based on that, you should see the image, just not the report by the radiologist alone. So you can plan the surgery accordingly and also the consent accordingly. And
and precautions you should take for DVTP.
Yes, ma'am.
Thromboprophylaxis. Post-operatively.
Post-operative remobilization, adequate hydration, anemia correction, and thromboprophylaxis.
Okay.
Is there any role of radiotherapy in this case?
Whole body radiation that to prevent recurrence before, ma'am, but now not it is
not whole body, whole abdominal.
Whole abdominal radiation is given.
Not whole body, whole abdominal.
Whole abdominal radiation. Intestinal obstruction, so many complications, we are not doing it.
So when there is recurrent disease, you can try, but it is not done because of the high morbidity. It is not used routinely. Okay. So if it is a younger age women, which malignancy is common? She's in the reproductive age group.
Reproductive age group, germ cell tumors account for 5%, ma'am.
Okay. In that, what the germ cell tumor is more common?
Dysgenminoma, ma'am, accounts for nearly 40%, and the immature teratoma 10 to 20%, ma'am. Other than that, we have yolk sac tumor embryonal cell cancer, and choriocarcinoma, ma'am.
Okay, so what you will do? What surgery you will do? The same, or surgery is different?
For germ cell tumors, we have to do unilateral salpingo-oophorectomy, ma'am, and then send the specimen for frozen section, and then complete the staging, ma'am, and then follow up the patient, ma'am, with chemotherapy, ma'am. Adjuvant chemotherapy, we are using BEP regimen for germ cell tumor, ma'am, bleomycin, etoposide, and paclitaxel for 3 to 4 cycles platinum.
That is called, what is that called? Fertility sparing.
Fertility sparing surgeries.
Okay. So once the family is complete in borderline tumors,
yes, ma'am.
You can.
Actually, borderline tumors, they are low
germ cell tumor once completed.
Ma'am, we can do hysterectomy with bilateral oophorectomy, ma'am, if the family is completed.
Okay,
along with surgical staging and adjuvant chemotherapy.
So what about borderline tumors?
Borderline tumors, they account for 10 to 15%, ma'am. Usually they present a decade earlier compared to other serous epithelial ovarian cancers in 40 to 50 years. There will be involvement of the, there will be a nuclear atopia and epithelial proliferation without stromal invasion, ma'am. There is low malignancy potential. I'll do surgical staging and unilateral salpingo-oophorectomy if the patient family is not completed, or TH with BSF, the family is completed, ma'am. And then I'll do omentectomy, pelvic lymph node dissection, and adjuvant chemotherapy is not needed for borderline tumors.
So just follow up the patient. So what about the sex cord cell tumors,
ma'am?
Which is common? Sex cord cell tumors, granulosa cell tumors.
Granulosa cell tumor.
So the report, nowadays you get many reports as granulosa cell tumor. What you do?
The granulosa cell tumor, unilateral tumors, ma'am. So we have to do unilateral salpingo-oophorectomy and staging, ma'am, and follow up with chemotherapy, BEP regimen, ma'am. Bleomycin, etoposide, and platinum.
Clear alla ennachu?
Somebody switched on the mute pananum. சண்முகடிவு.
சொல்லுங்க ராதிகா.
அந்த ஒரு இது
டாக்டர் சீதாராமன் யாரோ இருக்காங்க இல்லையா?
Can you please mute and
சீதாராமன் யாரோ
பேக்ரவுண்ட்ல வேற மீட்டிங் நடக்குதோ நான் கேக்குறேன்.
ஸ்ரீதேவி டாக்டர் சீதாராமன் யாரோ அவங்க மியூட் பண்ணி விடுங்க.
ஓகே
மேடம் மியூட் பண்ணியாச்சு.
அனிதா மேம்
மியூட் பண்ணியாச்சு மேடம்.
ஓகே மேம். நீங்க எதுவும்
கேட்டுக்கிட்டே இருக்கோம்ப்பா. ஒரு வாரமா திரும்ப இதேதான் கேட்டுட்டே இருக்கோம். அதனால இப்ப உங்க டர்ன்ஸ் நீங்க கேளுங்க, என்ன ஆன்சர் பண்றாங்கன்னு பாக்கலாம்.
அந்த ரீசெண்டா அந்த இது பண்றாங்கல்ல இன்ஃபியூஷன் கீமோதெரபி அந்த
hyperthermic intraperitoneal chemotherapy, ma'am. After doing optimal cytoreduction
in the operating table itself, we have to give a heated chemotherapy, that is installation of heated chemotherapy to a temperature of 41 to 43 degrees Celsius with a contact time of 60 to 90 minutes, ma'am. So that heated chemotherapy inside the peritoneal cavity, which increases the absorption without increasing the systemic side effects, ma'am.
Drugs we are using is mitomycin, 5-fluorouracil and platinum compounds, ma'am. Another thing we have is pipette, ma'am, pressurized intraperitoneal aerosol chemotherapy, ma'am. We are giving chemotherapy under pressure 12 millimeter mercury, ma'am, for more absorption.
Okay, super.
Okay, for we are doing genetic analysis and it is BRCA 1 and 2, 1 or 2 positive. So yes, what you will advise for that woman? She has come to you.
If the patient is not completing her family, we have to advise chemoprophylaxis with
Ma'am, I'll screen the patient, ma'am. Risk of cancer algorithm. If the patient is low risk, I will screen her annually, CA 125. If she is of high risk or intermediate, I will screen it for once 3 to 6 months, ma'am. And if I'll accordingly, I will do transvaginal sonography. I will plan according to CA 125 levels, ma'am. And then Ovarian test is available recently, ma'am, where we are taking into consideration CA 125, leptin, osteopontin, insulin-like growth factor 2, and macrophage inhibitory factor, ma'am. These are recent things, ma'am. And then if the patient has not completed the family, means I will give OC pills for 5 years, ma'am, because it reduces the risk by 50%. And if she has completed the family, I will do prophylactic bilateral salpingo-oophorectomy, ma'am.
It opposes
96% protects against ovarian cancer and 50 to 80% against breast cancer.
Okay, so when you are doing the bilateral salpingo-oophorectomy, you should remove the entire no tissues of tube or the ovary should be left. That you should be careful, and also you should screen for the. You said only for the ovary.
Annual breast examination, ma'am. Yes, ma'am. From 25 to 29 years, we have to do annual breast examination and annual ultrasound breast, ma'am. After 30 years, we have to do annual mammography and MRI contrast, ma'am, alternatingly. And
I'll follow.
Okay, so you should screen for breast cancer also. You should screen if the patient is positive. Okay.
If the patient has Lynch syndrome or HNPCC, means the risk of endometrial cancer is 50% and ovarian cancer is 10 to 15%, ma'am. So I'll be doing colonoscopy from 20 years annually, ma'am. If she is having, if her relatives or first degree relatives have history of colon cancer or endometrial cancer.
An endometrial biopsy from 30
years onwards.
Okay, ரெண்டு பேரும் படிச்சதெல்லாம் சொல்லணும்னு முடிவு பண்ணிட்டீங்க போல இருக்கு. இந்த மாதிரி நான் இதை கேட்கவே இல்ல. கேட்காம எக்ஸாம்ல ஆன்சர் பண்ணினா எதுலயாவது மாட்டிக்குவேன். சரியா? ஓகே. சம்பத் மேடம் இருக்காங்களா லைன்ல? Radhika? Radhika?
சம்பத் மேடம் மீட்டிங் போயிருக்காங்க. ஹலோ சண்முக வடிவு.
இல்ல அவங்க மேடம் யாரா இருந்தாங்க. அதை எதை ஆட் பண்ணணுமா, திங்ஸ் எதை ஆட் பண்ணணுமா?
நம்மளே மேனேஜ் பண்ணிக்க சொல்லிட்டாங்க மேம்.
Okay, okay, okay. Although ovarian malignancy, I think we have discussed everything. So when the patient just to come with the ovarian,
ஒரே ஒரு क्वेश्चन
simple ovarian
ஒரே ஒரு क्वेश्चन இப்ப young patient
what stage or what size based on the ultrasound and clinical pictures, at what stage you will operate and what stage you will just observe.
I mean, premenopausal woman. So from 5 centimeter to 8 centimeter, we have to observe, ma'am, for ultrasound once in 6 months for resolution. And if not the over not resolute, we have to do yearly ultrasound for follow-up, ma'am. If the size is more than 8 centimeter, we have to evaluate, ma'am, with CA 125 and manage accordingly, ma'am. For postmenopausal woman, if the tumor size is more than 5 centimeter, we have to evaluate and treat, ma'am.
So less than 5 centimeter?
Ma'am, we have to observe, ma'am. Follow up with ultrasound, ma'am, every 3 to 6 months, ma'am.
Okay, in reproductive age, in perimenopausal age group, less than 5 centimeter, mostly it will be a either it is a corpus luteal cyst or it will be a physiological one. So you need not just reassure the patient. Okay. So
Radhika madam endo கேட்டிட்டு இருந்தாங்க infertility னு ஏதோ கேட்டாங்க.
இப்போ young 19 18 yearsல வராங்க. அப்போ what will you do, like if you have to take the ovarian cyst ஒரு பக்கம் இருக்க malignant ன்னு தெரியுது. So what can you do? Chemotherapy கொடுக்கிறோம். அதுக்கு முன்னாடி can you preserve?
What will you do? She has to plan for
preservation, ma'am. Cryopreservation we can do.
Okay.
Before giving chemotherapy.
Before giving
Yes.
chemotherapy.
Anything else? ஒரு கேஸ் தானா மேம்?
Ovarian தான்.
அனிதா மேடம் பயங்கரமா ட்ரெயின் பண்ணிட்டீங்க இந்த பசங்க. இதுக்கு மேல என்ன அவங்களே எல்லாத்தையும் பேசி முடிச்சிட்டாங்க.
பத்மா மேடமோட ட்ரைனிங் ஃபுல்லா.
இல்ல எனக்கு அதுக்கு மேல கேள்வியே கேட்க முடியல. எனக்கு என்ன கேக்குறதுன்னு தெரியல.
எல்லா பாயிண்டும் மோஸ்ட்லி கவர் ஆயிடுச்சு. So very good. நல்லா பிரசன்ட் பண்ணாங்க.
Both of you answered well. Very good presentation. Okay, we will see in the exam how you are.
Hello, madam. I have joined from other number, Dr. Bhattacharya.
வாங்க மேம்.
பத்மா நீங்க ஏதோ கேளுங்க பத்மா.
நீங்க கேளுங்க மேம்.
அங்க
Is there any trials that is going on for screening?
Yes, ma'am.
Trials.
Yes, ma'am. We have ICON trial, ma'am. International Collaborative Ovarian Neoplasm Trial 1, according to which, if the patient early stage high risk patients, ma'am, we have to give if we are giving adjuvant chemotherapy, it improves the 5-year survival rate from 62% to 73%, ma'am. And another trial called as Action Trial, ma'am, which is adjuvant chemotherapy trial in ovarian neoplasm, ma'am. In suboptimally debulked patients, if we are giving adjuvant chemotherapy, it improved the 5-year survival rate. But over a period of 10 years, they did a study and they found that not even only in suboptimally staged patients, even in optimal cytoreduction, we can give adjuvant chemotherapy, which improves the 5-year survival rate, ma'am. Desktop over trial is there, ma'am. So to select the patients for secondary cytoreductive surgery, ma'am, with chemotherapy or chemotherapy alone, in that we have to take into account the progression-free interval of more than 12 months and platinum sensitive disease, ascites less than 500 ml, solitary site of recurrence, and good performance status. We have to go, no peritoneal cancer, we have to go for secondary cytoreductive surgery.
Okay, your plan,
trials screening. Is there any trial that is going on for screening?
PLCO trial. Prostate, lung, colon, and ovarian cancer trials, where we are using CA 125 and ultrasound and screening the patients.
So, but finally they have given the outcome as it's not very effective in screening for the general population. Okay, only for the
only in BRCA1 and BRCA2 patients.
Okay, so if you have, it is you clinically you are suspected as a benign ovarian mass and you have done a laparoscopy. Saranya,
Okay, ma'am.
you've done a laparoscopy, you planned for a lap ovarian cystectomy.
Okay, ma'am.
And on putting the laparoscope, you see the suspicion, it's a bilateral cyst, and you find its a surface is irregular, and the suspicion more in favor of malignancy. What you will do, you'll proceed with laparoscopy, or what you will do?
Ma'am, I have to proceed with the staging laparotomy, ma'am.
So you should abandon the procedure and you should go for the laparotomy. So even if you planned a laparoscopy, you should not try to do a laparoscopic cystectomy and you should not proceed with the laparoscopy. So whenever there is a suspicion of malignancy, always do a laparotomy, because the
for appropriate staging and visualization
also
of
appropriate staging, and whenever there is a spill, the stage is upgraded. Okay.
So you should come
And also
out
you should be careful when you're operating for the endometriosis also. So recurrent chocolate cyst, what type of cancer you can get in that?
Endometrioid type of epithelial ovarian cancer.
So even that, if you're even that, you should send for the histopathological examination. Okay. So the chocolate cyst also you should send for histopathology, and always rule out endometrioid carcinoma. You should rule out malignancy. Okay.
So then what is the link between use of fertility drugs and ovarian cancer?
Even in the history you have asked, no?
So
you have
what
asked
is
the
the
ovulation index.
use of clomiphene citrate for ovulation induction, ma'am, increase the risk of ovarian cancer, ma'am, due to there is injury in the ovarian epithelium.
Not only clomiphene, it is all. Yeah.
So all ovulation induction drugs causes breach in the ovarian epithelium. So that's why OC pills and multiple multigravidas, they are protected of ovarian malignancy. But nulligravida and also when you are using for ovulation induction drugs, repeated ovarian breach will be there, and they are also more prone for ovarian malignancy. Yes. And whenever you are doing hysterectomy for premenopausal age group women, what is your decision about salpingo-oophorectomy?
We have to do salpingectomy, ma'am. The first 50% production, ma'am. 50% production.
Why?
Ascending irritants.
No, ma'am.
Ascending irritants or
high grade serous tumors are from the stick and scout, ma'am.
Concept, ma'am. Serous
Why
tumor.
do you remove the fimbria, ma?
So high grade serous cystadenocarcinoma usually arises from the fimbrial end of the tubes. So you do a salpingectomy. So whenever you are planning, whenever you are doing a hysterectomy, you do a salpingectomy. But salpingo-oophorectomy is based on the risk of getting malignancy. So when there is a family history,
personal history of breast cancer,
all this thing, whenever there is a high risk for malignancy, you can do a salpingo-oophorectomy. But or else you do just a salpingectomy. That's alone is enough. But you should remove the fimbrial end completely. Okay. ராதிகா வேற ஏதாவது கேளுங்க, நீங்க நிறைய கேள்வி கேக்குறீங்க ராதிகா. ராதிகா வந்து ஹாஸ்பிடல் இல்லைனாலும் ராதிகா வந்து நிறைய கேள்வி கேக்குறீங்க, வேற ஏதாவது கேள்வி?
Virtuous nodes left supraclavicular nodes, ma'am. It is involved in ovarian carcinoma, ma'am. The lymphatics from the upper limb, abdomen, and left side of the chest drain into the cisterna chyli, and from there to the thoracic duct, and it drains into the junction between subclavian vein and the internal jugular vein, ma'am. The duct of the left supraclavicular node also drains in the same site. So there is retrograde dissemination of the tumor to the left supraclavicular lymph node.
So on examination, you have to say supraclavicular nodes also.
Yes, ma'am.
Okay. General examination. As you go, you have to examine the supraclavicular nodes and the breast.
Axillary notes and
Okay.
instrument notes.
Okay. Then what else? So in a case of ovarian malignancy, will you do histology before you try, endometrial? Will you go through the DNC, the endometrial, what you fractional curettage, or will you take an endometrial biopsy before going for laparotomy routinely?
Yes, ma'am.
Okay. Why?
Institutional protocol. We are doing it.
No, that protocol, there should be some reason for the protocol.
Coexistent endometrial carcinoma.
Very good. Okay. Sometimes endometrial cancer can have secondaries there, or it could have spread from here. Okay.
So whenever the patient is having postmenopausal bleeding, or when there is many other history of AUB, you have to do a endometrial biopsy also. So whenever there is a history, you do. Okay.
It's always better to do EUA, like Madam said, examination anesthesia. Even if it's a big tumor under anesthesia, it will be easy to examine and look for and also parectal examination. It will be comfortable for us and for the patient. So simultaneously, we can take the biopsy, examine the cervix also, and take biopsy, and then proceed. Okay. Okay. And you have to explain clearly communication to the patient, and the attender is more important, the relatives, about the prognosis and the management. Everything should be coordinated. Okay.
Okay, pa. Radhika, close பண்ணிக்கலாமா?
பண்ணிக்கலாமா?
Thank you very much.
Madam, நீங்க ரெண்டு பேரும் add பண்றீங்களா?
Madam,
thank you very much, Dr. Vadivu and Radhika madam, for
thank you, ma'am.
enlightening our PGs.
நீங்க ரெண்டு பேரும் இன்டர்னல் ரெண்டு கேள்வி எதை கேளுங்க.
நாங்க டெய்லி ஒரு வாரமா அதுதான் பண்ணிட்டு இருக்கோம். திரும்ப
நாங்க வீடியோ போஸ்ட் பண்ணி how did our PGs do, madam?
They did very well.
நல்லா பண்ணாங்க ரெண்டு பேரும்.
நல்லா பண்றாங்க.
Thank you.
ரெண்டு பேரும் நோவாக்க கரைச்சு குடிச்சிட்டு வந்துட்டாங்கன்னு நினைக்கிறேன். ஏன்பா நோவா கரைச்சு குடிச்சிட்டு வந்துட்டீங்களா?
கடகட பொழியிறாங்க.
நோவா கஞ்சி கரைச்சு குடிச்சிட்டு வந்துட்டீங்களா ரெண்டு பேரும்? Very good.
We would like to thank
you maintain the exam also.
Okay, ma'am. Okay, ma'am.
Yes, ma'am.
Thank you.
Anita, ma'am.
And we would like to thank TNFOG for organizing such a nice program for PGs, where we have all the PGs from Tamil Nadu to get benefited by this type of teaching for the PGs. Thank you very much, TNFOG, for organizing such a.
Ma'am, we want to thank, ma'am, we want to thank you all, ma'am. We want to thank Shanmugavadi ma'am, Radhika ma'am, our HOD ma'am, Anita ma'am, and Padmapriya ma'am. Thank you for giving us this opportunity, ma'am.
Thank you. Thank you.
Thank you, ma'am.
Okay. Thank you, Radhika. Thank you, Anita.
Thank you, ma'am. Thank you, Shanmugavadi ma'am. Thank you,
Convey
Anita.
my thanks to Sambat madam and
Ma'am and Revati ma'am. Definitely.
Thank you, ma'am. Thank you, ma'am.
Thank you, everybody. Thank you, Sagiti, and
Thank you, ma'am.
Thank you so much.
Thank you.
Thank you. Thank you, ma'am.